Hello everyone, this is Saman Salim at SS Medics, and today we will discuss a very important AMC clinical topic that repeatedly comes in the exams, which is approach to the epigastric pain. So let's start. Here is a typical example scenario that 45-year-old male has presented in emergency with severe epigastric pain for last 2 hours. Pain is associated with nausea and vomiting, and it is not relieved by Panadol. You are working as an HMO in emergency, and your task is to take history, investigations with rationale, and management. Now we will do the scenario in 3 different ways. One is this way. The other will be the where the task will be the examinations, and I'll tell you the third way while we are doing it. So while we are reading the scenario outside, and we have 2 minutes, and in those 2 minutes, the important things to be noted here are: number one, the age of the patient, which is 45-year-old. We have to keep this in mind because if the age is more than 40 and he has presented in the emergency, and if he has any risk factors for the serious disease, then we have to do the ECG. And since he has presented with severe epigastric pain, which can be an atypical presentation of an acute MI, so we definitely have to keep that in mind. So while in those 2 minutes thinking of our differentials, which may look something like this: it can be myocardial infarction, it can be pancreatitis, it can be peptic ulcer, it can be simple GERD, it can be Malady-Weiss tears, and it can be cholecystitis. Let's start with our history. In the history, firstly, we will ask the pain questions, that exactly where is the pain and how severe is it, if you need any painkiller right now. And after we have relieved the pain of the patient, we'll ask the patient that since when he's having this pain, does it go anywhere? What was he doing at that time when the pain started? Was it sudden or gradual? Is it continuous since then? Is it progressing? How is it progressing? Is it static, improving, or worsening? And can he describe the pain for me? Is it the first time you had this pain? Was there any trauma to your tummy? Is there anything that makes it better or worse? And are there any associated features? From the notes, I can see that you're having some nausea and vomits as well. So how many vomits did you have? Were they projectile? Was there any blood in them, or was there any particular odor? Then some other associated features, like is there any swelling or abdominal distension? How's your pee and poo? When did you last open your bowels? Has there been any passage of the black stools? How about your general health? Any past illnesses, diabetes, blood pressure, cholesterol issues, just to assess the serious risk status? Then do you smoke or drink alcohol? Has there been an incident of recent binge drinking, which may lead to pancreatitis, and it can also lead to Malady-Weiss tears or Boyer-Harvey syndrome? So that's where it's very important. Then has there been any history of the gallstones? Have you noticed any yellowish discoloration of your body? That's all, because we have already asked about the pee and poo, so let's not repeat our questions. So these are some of the questions in the history that we need to cover. Then the next part was investigations. Now, based on the history, what the examiners give, sometimes they give you a very characteristic history of acute pancreatitis, let's say. But other times they will not give you a very clear-cut history, and you will still be very confused after taking the history that what is the exact diagnosis. So if that's the case, that is the number one type of scenario that we are doing, that if the examiner or the role player does not give you a very clear-cut history regarding the diagnosis, then you have to tell your general investigations. And you have to say that from the history, I was not able to make my to reach any clear-cut differentials. I still have some differentials in my mind. I want to rule out myocardial infarction, so I will do the ECG. I want to rule out cholecystitis, so I will do the ultrasound. I want to rule out any perforated peptic ulcer. So I will do an X-ray erect abdomen to see the gas under the diaphragm. I want to rule out acute pancreatitis because you have been binge drinking and you take alcohol. So we'll be doing amylase and lipase and some other basic investigations like full blood count, LFTs and RFTs. So these will be the general investigations. But if the scenario moves in another way and the history was very characteristic that the patient has acute pancreatitis, that the pain was very sharp, it was present in the epigastrium, it was going all the way to the back as well, and patient had a history of the gallstones, or he may be an alcoholic or something like that, and the patient is sitting, pain relieves on leaning forward. So if some features are given which point towards the acute pancreatitis, then the examiner expects that you will tell the diagnostic investigations for acute pancreatitis, and you will mention some of the criteria for the prognosis of acute pancreatitis as well. So for the diagnosis, you will definitely need to do the serum amylase and serum lipase levels. You will do the contrast enhanced CT scan that might be needed in some severe cases. We might need MRCP. We might need ERCP or endoscopic ultrasounds as well. For the prognosis, if you cannot remember all of them, just remember the Ranson scoring, Glasgow scoring, and serum calcium levels. That's it. Now for the management part, what we are going to do is we will be admitting this patient to the hospital. We'll be offering them the analgesia. We'll be doing the fluid rehydration. If they need any oxygen, we'll be giving that to them. We will be frequently monitoring their biochemical parameters. If they have persistent vomiting, we'll definitely do the NG drainage. We will preferably do the enteral feeding until the complications like paralytic ileus, they start. In that case, we will start total parenteral nutrition. Antibiotic prophylaxis is recommended for moderate to severe cases. In mild cases, it is not normally recommended. And the antibiotic group that we normally give to the pancreatitis patients, that is from the carbapenem group. CT scans are normally done if the condition is continuously worsening. And if it was a gallstone pancreatitis, then we have to do the ERCP within the next 72 hours. And we have to do the sphincterotomy and biliary stenting for cholangitis. And if there is any organ failure, then we have to do the supportive therapy. Now, this is the third type of scenario in which they will change your tasks. The rest of the scenario is absolutely the same, but the tasks are now about the physical examination. Number 1, explain your physical examination of this patient to an intern. Number 2, explain the important landmarks. Number 3, explain approach to the patient. And number 4, explain your examination in a systematic way. So these days, as they are doing the online exams, so these are the 4 common task scenarios that they give in a station of physical examination. All of these 4 tasks, they basically mean that you have to tell the physical examination of this patient in a systematic way. But while mentioning that physical examination, you have to tell approach to the patient, and you have to tell the important landmarks as well. And these are the points where most of the students get confused, that what do they mean by approach to the patient and what do they mean by important landmarks. So we will discuss those things. Firstly, I have written this examination according to the face-to-face format, that if you were to ask the examiner about the findings, so you'll simply ask the vitals. You'll ask in the general appearance, how's the patient looking, what is the posture of the patient, how's the orientation and mentation, any icterus, any signs of dehydration. And then on abdominal examination, on inspection, if there is any Gray Turner sign or Cullen sign, on palpation, if there is any guarding, rigidity, tenderness, or epigastric fullness, on percussion, if there is any ascites with shifting dullness, and then on auscultation, are the bowel sounds audible or not. Then we will do the auscultation of the lungs and CVS if there are any findings there. And lastly, if there are any red tender nodules seen on the legs, which are indicative of the necrotic pancreatitis. So this is the format in which we normally ask the examiner for the findings. But this was in the face-to-face exam. These days, what you're going to do is you will tell the whole examination in the very similar approach that you normally conduct an abdominal examination. But for the approach part, that mostly students get very confused. So what do you mean by approaches? You have to start say like after reading the scenario, I have reached to certain differentials which include this, this and this. So while keeping these differentials in my mind, I will start the examination by following the wipe technique, which basically means I'll wash my hands, I'll introduce myself to the patient, I'll do the appropriate position, which is lying flat. I'll ask the patient for the pain relief and the adequate exposure, which is from the nipples to the mid-thigh. But because of the social constraints, I might do the examination under the compromised settings as well. Then firstly, on general appearance of the patient, I would like to look whether the patient is very sick or toxic looking, and if the patient is in marked distress. The next thing, as the patient is in emergency, the first and the foremost thing I want to do is to check for the vitals. And since my patient is in the emergency, so I would like to do the focused examination first, and then I will check the relevant systems. And then you'll tell for the focused examination how you do a normal abdominal examination, all the steps on inspection. I'll start from the bed end, I'll look for these things, then I'll go on to the patient's side. I'll bend to the so that my eyes are at the level of the patient's stomach, and then I will inspect again, do the inspection. Then I'll do a superficial palpation, then deep palpation to check for the organomegaly and everything like a normal abdominal examination. What are the important landmarks that you should mention in this case? In this case, mainly there is simply that you can mention about the epigastrium, that it is an area just below the lower end of the sternum. You can explain the Cullen sign and the Gray Turner sign, that this is the reddish discoloration in the flanks and the umbilicus respectively. Otherwise, there are no such landmarks in the abdominal examination that you need to mention if you're doing it particularly keeping acute pancreatitis in mind. If you are doing a scenario of CVS, then you can mention where the apex beat is heard and what are the four valvular areas where you auscultate. You have to mention their positions, etc. If you are doing lungs examination, then definitely you have to tell about the trachea and how to locate it, and about the sternal angle as well, because from there you will count the intercostal spaces. So that's all. These are the two things that mostly students get very confused about, that what to mention in the approach and what to mention in the landmarks. So in the approach, basically, apart from the wipe technique and apart from the basic things, that in the emergency, I'll firstly check for the vitals and I'll do the focused examination first and then do the relevant system examination. The most important thing that most students miss is what is the outcome that I want to intend. And to describe that, you can simply tell the differentials that you have in your mind before you're starting your examination. And by the end of the examination, I want to reach to some positive and negatives of those differentials. So since these are my differentials, my approach will be keeping those differentials in mind and then doing my examination according to that. That's all from my side. Hope I have cleared some of your queries. So if you have any questions, please drop them down in the comment section. I will try to answer them, and best of luck for your exams. Thank you.